So let's start with the today's mock session. Those who joined the first time today, let me have just quick little overview. This is Medical MCQ for All is a company. I'm the founder and CEO, Dr. Munjal. By profession, I'm hemato-oncologist and bone marrow transplant for almost practicing more than 20 years now. And my expertise is all in hemato-oncology and bone marrow transplantation. But I have a keep deep academic interest. So this type of mock test we are doing every Sunday for last more than year without failure, right? So you are most welcome in all mock test. And honestly speaking, if you listen me today properly, you get lots of clarity. Believe me, and it would be absolutely enjoyable session. So just stay tuned, concentrated, and we'll definitely discuss each and everything in detail. It's not just like a just I'm reading the question and going ahead. That's it. It's not like that. We absolutely understand the things well, right? So our main goal is to get the complete basics, right? That what we do, how we do. So all clarity will be there, especially for those who are joining first time. You get a lot of clarity. So we have a very nice team. I have more than 20 years of clinical experience with teaching experience of more than 10 years. I'm also a member of American Society of Clinical Oncology. So that's it. We have Dr. Aarti in our panel, who is a consultant pediatrician, Dr. Maddy, internal medicine, Dr. Ankit Patel, who is a consultant DNB gastroenterologist, Dr. Shikha, Dr. Deepali, and it's quite big team who will going to help you for all the various things. And this Anjali Sawant is based at Dubai, so she is completely handling the data flow, license transfer, license change, documentation, exam booking, or anything related with PSV or data flow. She will able to help you out. The number is here, right? And it's there on our website. This is recently updated book for PROMETRIC 1000 MCQ. After many requests of doctors, like the budget was bit high earlier in our package, so we stretched down to a very low, close to 60 to 70% discounted rate. It's all done. Not this is 50, but it is more than 70% now, 60 to 70%. So you can inquire later on if you are really interested in coaching. Data flow, as I told you, Dr. Anjali, all numbers are there. You can get it from our website, or these are the numbers. So you can call her directly, right? And we recently added last couple of months back new mock test. One thing I would like to mention here. Unfortunately, you guys are not doing a lot of practice of mock test, because I can see from my admin panel which doctor has given the mock test, right? So we have so far more than thousands of doctors using the website, but I am seeing hardly 10 people are giving mock test per month, right? So I think you should give more mock tests, try to assess yourself, check your score, discuss with me, discuss with my panel, discuss with anybody. So that makes you to improve your score really, right? So don't shy, don't hesitate to give mock test. Don't afraid of giving maximum mock test you do. And we have a separate completely module on our website, mock test, right? So you give, and I also upload every week one new random mock test that also give you, and I'll also send the results to the doctors directly in their WhatsApp by me only, right? So I am interested in your score, but you should be same. You have to be more interested than me. You are going for exam, right? So you must know the score, and it's good time to give the exam when you get more than 70 75% in 3 to 5 consecutive mock tests. Then it's a good time to go for exam. This is general surrogate marker, but very important by my experience, right? So mock test is extremely important. All are there on the website, subject wise and mixture of all as well. So try to utilize it. And these are the various packages, as I told you, 60 to 70% discounted. Inquire later on. And this all 10 things you get it in your combo offers. And last but not the least, before the class, strongly recommendation to subscribe our YouTube channel on the same name, Medical MCQ for All, with the same picture, right? There are hundreds of tremendous videos are uploaded there, and fortunately it's a free access. So you can subscribe it, so you get all the notification, and we have hundreds of past mock test videos are also uploaded there. So you go and check it and you can listen at least one video a day. You get lots of concept clarity. And this video is absolutely, I mean, subject to the exams only. No here and there talk, nothing. Only dot points related with the exam. And last thing, this mock test, all questions are different. So don't consider that 1 month before it's a same questions, 2 months before. Absolutely, it is all 100% different questions. So you see any videos, it's all 100% different. So let's start with this mock test of 17th 11 today. So get ready with your pen and paper, questions, answers, and we'll discuss each and every questions in detail. So first questions in front of your screen, 28-year-old woman with in her 27 weeks of gestation presents for a routine prenatal visit. She has no complaint on physical examination. Her temperature is 37.2. Blood pressure is 120 over 80. Heart rate of 87. Patient is asked to ingest 50 gram of glucose and have her blood glucose checked after or in 1 hour. It returns as 190 milligram per dl. Which of the following is the best next step in the management? Treat with insulin, treat with sulfonylurea, do a fasting blood glucose level, or do an oral glucose tolerance test. So you have a chat box there. You can post your answer in the chat box so you can get the idea and we can discuss as well. Yes, so now let's start. For those new first time join, I will always explain that this triad of MCQs. We'll start with this. You must know the investigation, you must know the diagnosis, and you must know the treatment. So if you know the three things in any MCQ, believe me, you are a master. So your job from now onwards, whenever you solve one MCQ, you need to solve three things in one MCQ. What's the investigation? What's the diagnosis? What's the treatment? So if you are solving 100 MCQ a day, you are solving the 300 MCQ a day, right? So that's it. So you can answer these questions. Try to understand. Yes, Dr. Javed Qureshi, what's your comment?
Sir, we have done 50 milligram OGTT and it
Yes,
has
sir.
turned positive, sir. So
Okay, sir.
we need to do further testing to confirm the diagnosis. We will do 3 hourly OGTT with 100 milligram of glucose and
Okay,
then confirm so that
okay,
we know that it's a gestational diabetes. Then we can proceed ahead, sir.
okay. Excellent. Wonderful. So what do you think? Let's go to this triad, right? So what do you think? Right. So they are asking the management or what is the best next step, blah blah blah. So what do you think? What could be the provisional diagnosis of this patient?
It's a gestational diabetes, sir.
Sorry, gestational diabetes, right? Gestational diabetes mellitus, right? Okay, fine. So when the 50 grams glucose, what is the normal range, right? If this number is 150, but if this one number is 130, then how this MCQ will change? How this MCQ will change? Same scenario. I'm putting here the 130 instead of 190. I put the 130.
Sir,
What's your diagnosis?
usually the postprandial glucose we take it at 180. So if it is below 180, we will take it as a normal OGTT and no further investigation is needed.
Fine. So let's assume that this MCQ runs completely as it is. Instead of 190, 130 is there, right? It returns as a 130 milligram, right? What you want to do? You can say, for example, nothing to do here, another, right? Right? F is diet, exercise, or it is a normal. These all are the options in, right? 130. How your answers gonna change in this? Anyone? You are excellently well, Dr. Javed. Going well. I'm happy. That answer was correct. Perfect. The answer is oral glucose tolerant test. But I want to understand. I want you to make more thinking of your brain. If this comes as 130, then how you gonna change? What's your answer? How you manage this patient? Anyone? Those who posted the answer, you can. Yes, Dr. Jonah. Joanne, right? Your is Joanne. Joan double N E. Joanne.
Sir, for 130 also we need to investigate, because above 120 odd we have to investigate. I don't remember
120.
exactly. It's 126 or something.
Okay.
Even
So what's your homework, sir? What is a normal in pregnancy, right? What is a pre-diabetic in pregnancy? What is a diabetes or gestational diabetes mellitus in pregnancy? You must know because they may not ask you the same question, right? They may ask you some other related with this. Probably they say here 115. Say for example, how your treatment or how your management will gonna change. You need to know. If it is 150, forget about 130. Now 115 is the answer here. The question, it returns as a 150. Which of the following is the most next appropriate step in the management? Now you tell me.
if it's 115, sir, then no further investigation is needed.
Okay, no further investigation is needed. Fair enough. Let's see what other experts are saying.
So the cutoff value is 140 for 50-gram oral glucose load, sir. If it is less
Okay,
than 140, diabetes is unlikely. And if it is more than 140, we have to go for OGTT.
okay, fine. So this candidate basically deserves, right? This is 190. So absolutely there is no controversies, right? 190 here it is absolutely readed oral glucose tolerance test. Is that correct? Yes or no?
Yes, sir.
Right, wonderful. So now you need to know, right? You don't need to mug up, right? So what is the guideline? I'm talking absolutely the guideline, right? Without guideline, we will not discuss any questions because this is we are doing the sincere job here, right? So an oral glucose tolerance test should be done after a positive glucose load test, as described in the question. So questions described everything, right? Fasting blood glucose is not used for the diagnosis of gestational diabetes. So right,
Yes.
non-pregnant women, like if me and anybody's male female suspected who is not a pregnant, right, you do fasting blood glucose. Four criterias, let me tell you, even non-diabetic patient, four criterias to diagnose. Four criterias, I'm talking about non-pregnant male female, right? So one is fasting blood sugar, one is postprandial blood sugar, right, third is a random blood sugar, and fourth is HbA1c. Anyone wants to comment on these numbers, right? So fasting blood sugar of more than 125, right, means it is anything more than 125, rather better is 126, right? Anything more than or equal to 126 is a fasting blood sugar in a two different occasion. Remember, this word are very important. Two different occasion means they have done today is the 17th of 11, 6 a.m. fasting blood sugar is 120 130 fasting. And what is the definition of fasting? At least 8 to 8 hours minimum, desired is 12 hours overnight fasting, right? So if you have somebody's taken 8 o'clock in the night last meal, morning up to 8 he has not consumed anything, 12 hours of fasting. This is the definition of fasting. So fasting of 8 to 12 hours, desired higher the better, right? So 8 to 12 hours of fasting, right? And if the blood sugar is 126, say for here 130 patient, again next day morning you do in a two different occasion, not in one occasion. This is definition by American Diabetic Association, which is as per the guideline. Again, next day morning, he has a 135, say for example. This is a pakka case of diabetes. This is a confirmed case, right? So, diabetes definition is more than 126 in a two different occasion in a proper appropriate fasting condition. So, this is one of the criteria in preg- non-pregnant. We are talking about non-pregnant. Fasting postprandial 200. RBS, random blood sugar, right? This 2 hours. After 2 hours of meal, if your sugar is 200 or plus, it's random blood sugar in symptomatic patients, symptomatic polyuria, polydipsia, polyphagia, weight loss, blah blah. Symptomatic plus 200, random considered diabetes, and HbA1c of more than 6.5%. It is in the percent, right? or it is called as a glycosylated hemoglobin, right? So what happens in the blood? In the blood, there is a RBC, and in the blood, there is along with the RBC, there is also a right along with the RBC, right? There is a glucose. So glucose is attached here, right? So more glucose, more it is attached. So anything more than 6.5, right? HbA1c in a single reading. Here, two different occasion is not required. It's just for the fasting only. Two different occasion, right? Two different occasions. So this is what the classical international definition of diabetes diagnostic. So any patient you want to diagnose as a diabetes, these are the four criteria. You go and check it as well, right? So this is ADA. Now let's come and switch the gear to non-pregnant. Or sorry, pregnant. So these all are about non-pregnant. Now pregnant. So pregnant oral glucose tolerance test has to be done as a positive load test as described in the questions. Fasting is not at all required here. Gestational is important, right? And treatment of gestational diabetes start with the diet and exercise. So this is another question in exam, right? So once you diagnose, say for example, gestational same patient is 190 blood sugar as we see, right? Oral glucose tolerance test we do, and in oral glucose tolerance test is positive, then first treatment is a diet and exercise. Diet and exercise. You cannot replace diet and exercise. Then the best immediate is the insulin. Patient refuses insulin, you can use the metformin. This is what the guideline is. So treatment for gestational diabetes start with the diet and exercise, right? If the control fails, sugar is high, right? So medication is indicated with the insulin is the gold standard. And for the patient who refuses, intolerant or any complications, right? You can use the metformin and sulfonylurea as well. That's it. So this is what the thing is. So you need to go and check exactly the complete. So say for example here, let's Dr. Javed told, right? So what we are here interested more. So what happens after 1 hour? What happens after 2 hour? What happens after 3 hour? So that could be your homework. So 50 glucose load test is positive. Now you are doing the oral glucose tolerance test, OGTT. Oral glucose tolerance test 1 hour. What is the desired result of sugar? 2 hours, what is the desired result? 3 hours, what is the desired result? Which confirms that this is a case of gestational diabetes mellitus, right? And which numbers suggest pre-diabetic as well. You need to know. They ask you the pre-diabetic range as well. So this is, if you don't know, go and read it just to save the time. I'm switching to the next question, but you must know all the things, right? So your homework for today is to go and read completely gestational diabetes mellitus. So answer for these questions now. Those who has given the different answer here, do an oral glucose tolerance test. Treat with the insulin is bit premature. Why? Because still you did not confirmed it with the confirmatory test OGTT. Treatment comes later on, and fasting has no role in gestational diabetes mellitus. It's in the non-pregnant woman or non-pregnant male, female, blah blah. Right. So that's it. So this is what the answer is. So let's jump to the next question. This is a chart from the international book, standard book. What they shows glucose load test, non-fasting ingestion, or 50 gram of glucose followed by serum measurement of glucose after 1 hour. So 50-gram load after 1 hour. See here, Dr. Noah, I forgot your name, but the
Joe
here the range
Morrison.
is yeah. So less than 130 to 140 is the range. No gestational diabetes. So anything more than 130 to 140, right? Its oral glucose tolerance test is indicated. So here in our case, let's remember our case, right? What's our case was, right? So they have a 190 here. So instead of 140, our case has a 190 sugar. So they deserve more than 140. They deserve OGTT. So this is OGTT, oral glucose tolerance test, right? And now what they have observed glucose followed by the glucose measurement at 1, 2, and 3 hours. What, right? So 1, 2, 3 hours, this comes elevation of fasting serum glucose as 1 to 3 hours, 2 or more value elevated. 2 or more value elevated is a gestational diabetes. So if 1, 2, and 3 hours, you don't need to qualify this patient as a gestational diabetes mellitus, right? Two values, right? 1 hour or 2 hour is positive, 2 hour, 3 hour positive. Any two values positive, it's a gestational diabetes, and you start the treatment accordingly. So treatment I also very quickly mention you. So you go and read the gestational diabetes mellitus. That's it. Is that clear to everyone? Yes or no?
Yes, sir.
Dr. Noah is all clear, right? So
Sir,
wonderful.
if the value comes as 135, what do we do, sir? If in GTT, I mean glucose load test.
More than 130 as per this guideline, doctor, you do it. More than 130, you do it, right?
Okay. Yes,
More
go for
than
OGT.
130. Yeah,
Go for
exactly.
OGT.
So
Okay.
cutoff line is 130.
Okay.
Great, wonderful. So let's switch to the next questions. Very important. I selected all different subjects questions, so your overall knowledge will be also check, and you also check your score as well. You don't need to display to me end of the day, but you check out of 10 questions we discussed with all detailed explain how much is correct. If it is less than 50% score, it's not good idea. Need to work more on yourself. 22-year-old unconscious man is brought to the accident and emergency room. He was found lying alone on the street by passers by who called the ambulance, and the crew mentioned seeing needle on the floor. The patient's Glasgow coma scale is 12. He has a respiratory rate of 10. Blood pressure is 97 over 65. During examination, he noticed pinpoint pupil, and the most appropriate treatment is mechanical ventilation, IV naloxone. A third is IV naltrexone. So it naloxone and naltrexone is different, and methadone. These are the four options. So first again let's go to the basic. We need to know what's the diagnosis. So first of all, we need to know the diagnosis, right? So now, can anyone tell me, Dr. Murshida, what is the diagnosis in this patient? We'll go properly, concept based diagnosis, then investigation, and then treatment. We'll not bypass anything. We don't want to do any shortcut.
So this has to be some opioid poisoning, isn't it?
Okay,
Because he's
wonderful. So let's go me one by one. We will discuss with you complete questions, and I want you to give all answers. Don't worry. So your provisional diagnosis, doctor, is opioid poisoning, right? So now first of all, tell me what makes you to think of opioid poisoning in this patient so other people also learn.
yeah, so he is unconscious with
Why not organophosphorus poisoning? Why not aluminum phosphide poisoning? Why opioid poisoning?
it has a pinpoint. He has unconscious and pinpoint pupils,
So pinpoint pupil is one thing,
and the
right?
shallow breathing is there.
So pinpoint pupil is one thing which makes you to think of this. What other points? Because in scenario, everything is there. If you
Shallow
cultivate the
breathing,
practice, yes, tell me, sorry.
respiratory
Needles
rate
on
is
the
of the
floor.
10. So it is shallow breathing,
Typically,
and
respiratory rate 10 is a less, right? Because in adult at 22 years of age, your
yeah,
respiratory rate should be 16 to 20, 21, 22, right? Normal, right? So it is less. So respiratory, some kind of respiratory depression. Is that okay?
yeah.
Right. So this is another point. What third
Also,
point
that
here?
Needles on the floor, sir.
So needle on the
decrease
floor.
the
So
level
that
of
is again
You
consciousness.
a
must have
ne-
injected it.
needle on the floor. Maybe some looks like he has some drug abuse basically, right? We don't know
IVS.
what drug abuse. We don't know. By this we don't know because we did any toxicology, urine serum test, blah blah, plasma level of opioid. We have not done. As per the scenario,
Oh,
we have not done. You are suspecting something going fishy or wrong in this patient, right? So by this context of this patient, they are asking the directly treatment, right? So without diagnosis, how you gonna make treatment? So always make a health, cultivate the habit of doing the diagnosis. Once you make a diagnosis, treatment is very easy, very easy. Busy me, and they are directly asking the treatment. So tell me, how you gonna do the treatment without knowing the diagnosis of the patient? Almost difficult or impossible. Anyway, so pinpoint pupil, respiratory depression, needle is there. What else you can think of? Everything is in scenario. You look at
Sir,
the scenario 10
hypotension.
times. Hypotension.
Sir,
So
the patient
hypotension
has
is a
hypotension, and
hypotension. So
contrary to organophosphorus poisoning, there is no cholinergic symptoms.
right, that's correct. So hypotension. So hypotension is also one of the thing. So respiratory depression, cardiac depression, right? Cardiorespiratory depression, right?
Yes, sir.
Wonderful. So this all point favors are suspicious of opioid poisoning, right? So
Yes,
can
but
anyone tell me the name of any one opioid, the name of the drug of opioid?
morphine,
Wonderful.
codeine,
Morphine, codeine. Anyone else?
tramadol,
Opioid. Opioid
tramadol,
analgesic. So if you don't know, use go and read the opioid. Write down in the,
buprenorphine.
sorry to bother you 1 minute.
Oxycodone.
Write down write down everybody read, go and read the opioid chapter. one of the most very high yield questions, either OP poisoning, opioid poisoning, antidote, overdose, this absolutely high yield point. So you go and read it, right? So we are discussing here as far as possible, but this is second homework. One is a, here I write down gestational diabetes mellitus, one homework, another is opioid. It is commonly used drug in a severe pain score of 8, 9, 10. We use in hemat-oncology. Cancer patient, all cancer patients we put in terminal or very advanced stage, nothing works, morphine sulfate, fentanyl patch, durogesic patch, methadone. These are the drug of choice for us in oncology unit for cancer patient or cancer pain, right? So this patient, this drug is not just the poisoning, it is a good drug, it's good analgesic drug, but if it is an overdose, opioid, this cause all this. This is the sequence of the toxicity or
Tremol
overdose.
also is commonly used, right?
Sorry, madam.
Tremol. This is Amina. I'm logged in from my son's account. So Tremol, the medicine Tremol, that also has a lot of opioid in
Yes,
it, right?
that's correct. That's tramadol.
Tramadol,
We call it as a tramadol, right? So it is all come as a narcotic drug. Okay, fine. So now opioid, you are suspecting this patient as a opioid toxicity. What is the drug of choice? Why you, what
yeah.
exactly you want
Son,
to use?
Naloxone
Naloxone,
is the antidote.
Naloxone, right? Naloxone. So answer here is naloxone. Yes, that's correct. So those who have suspecting or those who have thought of or they put the answer B in chat box. Now, can anyone, any volunteer tell me what is the indication of naltrexone? What is the indication of methadone? Let's discuss that part because they may ask you naltrexone. Yes, now open.
Naltrexone, sir, we use for chronic opioid.
so for alcohol dependence,
So go and read this third homework. Naloxone versus naltrexone. Right. So what's the key difference? What's the key difference? Because this is also used in opioid poisoning, right? Or toxicity. This can also be used in opioid toxicity. But the biggest advantage is that this is the fast in action, this is slow in action. So in emergency room, you need something to work fast. Second thing is naltrexone, opioid, as well as alcohol. Alcohol dependence also you can use, right? And methadone is a drug. It is a strong, potent analgesic. It is used for the moderate to severe pain, right? Methadone, it is a drug of choice. So excellent drug, wonder drug. You need to know this all things, right? So whenever in the options, you need to know all things, right? You don't just need to know the answer. What is this? What is this? What is this? This is how you can improve your pharmacological knowledge as well, and which we must improve our pharmac knowledge as well, right? So this is
sir,
what the thing is, right? Yes,
sir, can you methadone के बारे में आप दोबारा बता सकते हैं?
I'm coming on that point, doctor. I'm
Okay.
reading that point right now,
Okay.
right? So sorry. Yes. So this is naloxone, right? So we are suspecting the opioid and opioid the right. What is the antidote of organophosphorus poisoning? If it is organophosphorus poisoning, if you are suspecting, what is the drug of choice?
So
From
atropine,
Atropine. Atropine.
Trazodone, sir.
Atropine and
Raloxime and atropine.
wonderful. Like that, you need to know the opioid number one, organophosphorus, right? Aluminum phosphide or hydroxide. Third, fourth, alcohol poisoning, right? Fifth, paracetamol or acetaminophen, and six, aspirin. If you don't know, go and read, we'll discuss. So these are the absolutely high yield point for the exam. I know because I'm doing this job for more than 10 years, coaching, doing, right? So what they ask, I know. So I giving you the idea, right? So if you don't know other part as well, you go and read it, right? We'll discuss in next lecture or so, right? So we are discussing now the one topic, right? So these are the things you need to write down alongside, right? So you will not miss out any points, right? For the exam, right? So here is what the naloxone is the antidote, right? So this is the triad. This is the classical triad of opioid toxicity, toxidrome. Three things is there. It's until proved otherwise. Altered mental status, CNS depression, euphoria, right? Pupil constrictions or pinpoint, and opioid-induced respiratory depression. So in patient, we have a respiratory depression, we have a pinpoint pupil, we have altered mental status. So this is absolutely classical triad of opioid toxidrome or opioid toxicity. The absence of meiosis does not rule out. So remember this. Few people say if there is no pinpoint pupil, that means that this is not opioid. It is not mandatorily. So, what is the clear cut sentence? I got it from the book while reviewing my lecture before presenting to you. The absence of meiosis means if the pinpoint pupil is not there, you cannot rule out that opioid intoxication. So, in absence of even pupil is not constricted or pupil is not pinpoint, even though there is a opioid poisoning. So, keep in mind, right? Don't get block your brain that oh, there is no pinpoint pupil, this is not opioid. It can be present, right? So, management as usual, airway, breathing, circulation, right? ABC and the naloxone, right? This is the main thing, right? ABC is always there, airway, breathing, circulation, any emergency. And naltrexone, I told you, used for the opioid and alcohol dependence, right? Plus slower in action. So it is not a good drug of choice in case of the emergency room, right? And what about the methadone? So methadone, as I told you, right? So methadone is the drug, right, which is used. So used parenterally methadone. This is about methadone. So used parenterally for the relief of moderate to severe pain has not responded to non-opioid analgesic. So you use the non-opioid like acetaminophen, you use, yes, you diclofenac, you use ibuprofen, you use blah blah, you use nothing help. Methadone is the drug of choice, especially not for mild pain, moderate to severe pain. So little go and read it, right? There are a lot of literature with this as well. I'll share this complete lecture end of the day with you,
Sir,
video
sir, I
lecture.
have a doubt. Sir, you mentioned that in respiratory depression you cannot use naloxone, like in respiratory rate less than 12. So,
Naloxone is an antidote, doctor. You can use, na?
okay,
No, less than 10 is the patient's, right? In this scenario, patient has a less than 10 respiratory rate. This is a signs of opioid poisoning, right? This is this 10. This 10 score is of because of poisoning, opioid poisoning. So there is a respiratory depression, there are cardiac depression, there is a pinpoint pupil. This all symptoms. This is respiratory depression, means respiratory is less. This is cardiac depression. This is respiratory depression. Pinpoint pupil. This is classical triad of
okay,
poisoning. Sorry, opioid poisoning. So opioid poisoning antidote is naltrexone. So if you give the naltrexone, it will reverse along with the ABC, right? So respiratory depression is a symptoms of poisoning, not the naloxone.
okay, okay, sir.
Great. That's it. So this is little easy questions, probably, but very important, and it's important. Right? So IV naltrexone is another opioid antagonist which has a longer half-life than naloxone, and so it is less often used in an emergency situation and more for long-term dependency control. Right? So anyway, so this is more so opioid emergency. If comes anybody, patient comes to you in emergency room, naloxone, but patient is dependent, right, on opioid, and you want to help the patient, then naltrexone, right? Because dependency is something not urgent, right? Something comes with a acute toxicity or poisoning, you use the naloxone, right? So they have clear cut mention in the book. IV naltrexone is another opioid antagonist, right? Means that can also be used, but what's the disadvantage? Which has a longer half life, right? Than the naltrexone, slower in effect, so less often used in emergency situation, and it takes more time to act on the CNS and heart, and that is why you need something to do a quick fix, and that is naloxone, not naltrexone, and it is more for long-term dependency control. It can be used. So you just need to remember in the exam if they ask, right? That's the important. Another tricky little interesting questions in front of you. 17-year-old male is brought unconscious to an accident and emergency. His friend report that they were at the nightclub while celebrating his birthday. 17 years old boy. He denies having any alcohol, recreational drug like marijuana, heroin, morphine. Did not consumed anything. They deny. The club has strobe light effect, and while this there were on the suffered, he was suffering from a seizure. The club has a strobe light effects, and the while this were on, he suffered a seizure. The friends called the ambulance after the seizure. While waiting, the patient suffered another seizure shortly after the first. He was not conscious during the attack of any attack of the seizures. The most appropriate treatment: intravenous lorazepam, rectal diazepam, intravenous thiamine, intravenous midazolam, intravenous thiopental. So you think over it. I'm not in hurry at all. Just take your 10, 15, 20 seconds. Again, as usual, I need first diagnosis and then treatment. Obviously, investigation is also there. So I can write down here. So without diagnosis, you cannot confidently give the answer about the treatment. They ask either three question in exam, DHA, HAD, MOH, whatever. Either they ask diagnosis, investigation, treatment. Here they ask in treatment. So think over it, what this patient is suffering from. Dr. Nasreen, any comment on this? Dr. Nasreen. Dr. Najish, any comment?
Sir, we use intravenous midazolam here in Pakistan. Like I've seen the first drug of choice, and the patient brought in an emergency department with fits. We give them IV midazolam.
Okay, so is there any advantage of giving midazolam over lorazepam? Just discussion purpose.
I think faster acting, or that may have rapid onset of action that Dr. Ravi is saying. Because lorazepam, we give the patients in maintenance doses sometimes.
Fine, fair enough. So what's the diagnosis, Dr. Nazis? What's the diagnosis? What do you think what this patient is suffering from?
He might be suffering from epilepsy because he is triggered by the lights, the fluctuating lights, and
Mhm.
but for
Okay,
epilepsy we will have to go for other tests. But this is
okay,
a seizure.
so if I can tell you this is a status epilepticus, then it is a correct sentence or it's not correct sentence? Or how you define the status epilepticus? Tell me. What's in your mind about the status epilepticus? There must be some definition, status epileptic. Okay, sir. This is the condition where we report, I mean, international definition of status epilepticus.
Sir, if a seizure is more than 30 minutes, then we can say this is an status epileptic.
30 minutes. So right, so seizure for 30 minutes. At that time, patient should be conscious or unconscious?
No, unconscious,
Patient
sir.
should be unconscious.
Unconscious.
Seizure
Okay.
more than 5 to 10 minutes
Sir,
continuously,
yeah,
or else
lines.
the patient is not regaining consciousness between two seizure episodes.
Okay. So once someone is saying 30-minute duration, what's the another definition someone told?
No seizure-free interval should be continuous seizure activity.
Sorry? So you can post in the chat box as well your definition. Everyone post your definition. I need two things. What is the time duration? What is the conscious level? Or what is a key point to diagnose anybody as a seizure? I mean, we need to know, na? I mean, how you define the status epilepticus, right? Somebody has 1 minute seizure, he is unconscious. Is it status epilepticus or something else? Somebody has 6 minutes of seizure without gaining the consciousness in between two episodes. Is it status epilepticus? So I want to know and want to clarify yourself what is the status epilepticus.
So
So
if
there
it
are
Single
four
seizures are
stages.
lasting for more than 5 minutes.
no, sir, if it is more than 30 minutes, then we can call it status epilepticus.
So
And
now this platform is little debatable more, right? So what the international guideline we go and we need to review it. Write down everybody's homework. No? This is what we need to do. No? That is why we are in the sitting and struggling on the Sunday rather than enjoying and moving around. We are sincerely doing our business. So everyone write down the homework. What is the definition of status epilepticus? Right?
It's basically if a single seizure is lasting for more
Within
than
5 minutes,
5 minutes,
period,
and
or two or more seizure within a minute. I think so, sir.
Fair enough, fair enough. But
Yeah.
you need to review, right? You
Yes, sir.
can't just sit,
Yeah.
yeah, you can't just sit at home. This is all high yield points, right? So until and unless this is absolutely concept based class, it's not mug up, right? Oh, blah 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 blah, right?
The seizure
Now, so
containing more than 20 minutes, or else more than one seizure without regaining consciousness.
so 20 minutes you told, sir, 20 minutes,
Yeah, more than 20 minutes.
more than 20 minutes. Okay,
Or else once more than one seizure without regaining the consciousness.
fine. So what I need your help. You need to find out the literature what you are explaining to me. This is absolutely scientific session, right? So we need a evidence-based medicine, right? Not my definition, Dr. Munjal. What I think is not true. What guideline says is true, right? So we need a guideline. We need a guideline. So everyone do the exercise. We'll discuss, right? Fair enough. So now what's the answer? If let me ask the two question in one question. Pre-hospital or or before IV access? What's the answer of same question?
Rectal
Before IV
diaphragm.
access, and
Rectal diaphragm.
once IV
Retinal
access is
diaphragm.
established,
So if
So
IV
the
access is established, IV lorazepam, sir. Option A. In acute condition, we should go for lorazepam.
excellent. So when
but sir,
IV
before
access is developed, it is lorazepam. So answer is A in lorazepam, IV access. But this patient is still
yeah.
struggling. He just entered the emergency, nothing established. So here the
Rectal diaphragm.
rectal diazepam.
Rectal diaphragm.
Sir, we
Yes,
can
sir.
give rectal or
Rectal.
intranasal method is also there, sir.
Excellent, excellent, wonderful. So rectal diazepam or as per the guideline, intranasal, right? Intranasal,
Yes, sir.
intranasal.
Especially
Which drug? Can you name the
midazolam.
drug? Excellent,
Midazolam, sir.
excellent. Intrazolum, midazolam, intranasal midazolam. So earlier you told me, Doctor, I forgot your name, Doctor Nazir or what? I mean, you
Yes,
told
sir.
something. This
International buccal.
midazolam in Pakistan. Somebody told me intravenous in Pakistan, right? So midazolam. So midazolam is as per the guideline. It's a intranasal, not intravenous, right?
Yes,
So
sir.
those just go and review the literature. What is the difference between lorazepam, intravenous lorazepam versus midazolam? Pros and cons. I can discuss, but it takes just long time. So I want you to also interact with me. So you go and read it. You go and read it.
Okay,
Lorazepam
sir.
versus midazolam. Why lorazepam? Why not midazolam? It's the guideline. Na? So there must be some reason. Probably it is slower in action, right? Fast clearance, right? More respiratory depression. That is why this is a drug of choice. So go and read it once again, right? So we need to
Okay, sir.
review the proper literature. We need to review the proper literature. This is not just
Okay.
simple class. This is a evidence based class, right? So here when the here the for this question it is a rectal diazepam. Once the IV line is established, then it is a answer is A. When there is a IV line, when the IV line is not there, right, it's a B. This is the answer. So here the B answer. Just arrived in the emergency room, you start doing it, resuscitate the patient, right, stabilize the patient, take IV line, and then you can, if the seizures persistent, you can go and look at the other options, right? So what is this? I also
Sir,
gathered some more info.
sir, lorazepam is a short-acting drug, and midazolam, so in a daycare surgery, in a daycare procedure, generally we use midazolam in a hospital setting.
Yes, that's correct, but we need to know the why in international guideline midazolam is not there. I'm putting all the
Okay.
things. If you are not agree with my answer, I would be happy. You need to produce the literature. That's it. Whatever I'm giving you the slide, it's all from standard book. And for this lecture, I preparing for years and years this class type. So I will take it all from the books. But if there is some discrepancy in the things, we can discuss. I will also learn. I would be happy. But you need to post something authentical in the group, right?
Okay.
Open group, so everybody will understand, right? So you go and review it. What's the definition? Seizure in children 6 to 5 years are associated with fever. This is called febrile, right? So what are the various febrile seizures? Simple seizure, complex febrile status epilepticus, blah blah. So let me, yeah, so this is the answer, rectal. First line treatment is to give rectal, especially pre-hospital arrival or pre-hospital when patient is not stabilized. No IV line, no catheter, no nothing, no ABC, nothing done. Just come give it. Once IV established, then you can give it the IV lorazepam. That is the drug of choice. That's it. So we'll go and review more literature after the class. Fourth question in front of your screen. 15-year-old boy comes to the office because of occasional shortness of breath every few weeks. Currently, he feels well. He uses no medication and denies any other medical problem. His vital
class
is sorry.
paragraph writing.
We will discuss. I mean, after class, we'll discuss. Keep in mind just. So I'll just finish it off. So his vital stable and chest examination is normal. Which of the following is a single most diagnostic test at this time? So again, I'm reading. If somebody missed, 15 years old boy comes to the office for the occasional shortness of breath every few weeks. Uh, right, breath every few weeks. Currently, he feels well, no problem, no breathlessness. He has not on any medication, no comorbidity, no problem. His vitals are stable, chest is normal. Which of the following is most likely or most diagnostic test at this time? Peak expiratory flow, increase in FeV1 with albuterol, diffuse lung capacity of carbon monoxide, 20% decrease in FeV1 with use of methacholine, increase alveolar oxygen differentiation A gradient, or increase in FVC, that is forced vital capacity with albuterol. Again, what's the diagnosis, what's the investigation, what's the treatment? 3 point in 1 point. Take your own time, not in hurry at all. We have time still more, close to 30-40 more minutes. So we'll discuss everything in detail properly. Because these questions I selected, all high yield, all little confusing with the concept clarity is very much important. So first of all, those answered, tell me the diagnosis, how you investigate, how you treat.
Sir, we need to diagnose this one as bronchial asthma. So first we have to do
So you are
methacholine
Shibilia?
challenge test.
You are
Yes, sir.
Shibila? Okay,
Yes,
fine. So
sir.
what's your diagnosis?
Diagnosis, we have to first diagnose this as bronchial asthma. So we have to do methacholine challenge
So
test,
this,
sir.
okay, so this is likely bronchial asthma, right?
Yes, sir.
Wonderful. So that we concluded to one thing, this is likely, it is not confirmed. Na? So this is likely or differential, most important differential, likely. Okay, fine. So when the patient is symptomatic and patient is asymptomatic, yes, Sibila, you tell me if you are suspecting some patient, right? So this
Yes,
patient,
sir.
first of all, we'll talk about this patient. He is asymptomatic now. You are suspecting bronchial asthma for this patient. What
Yeah.
test will confirm amongst this? Why you don't want to do PEF, peak expiratory flow, right? Peak expiratory flow is like a machine, right? Here, where you blow inside the things, and there is a yellow and there is a green, right? And there is a red, right? Which shows that when you blow the air, will go red is bad, yellow and green is good, right? This is how, have you seen
Yes,
the
sir.
peak expiratory flow? Yes or no?
Yes, sir.
Right.
Yes.
So this is not the test in this case. Why you don't want to use peak expiratory flow? Why you don't want to give the albuterol bronchodilator and then check the how we blow? FEV1 is what in simple language? Force expiratory volume in 1 second means what? Like it is in 1 second how much the air you blow. Whew. This is what the thing is, right? You
Yes, it
inhale.
should be. Yes, sir.
Oh, that is a FEV1. So these are the not good tests for this patient. I'm just trying to understand your concept. You tell me. You stick to your answer. I'm just trying to discuss with you.
Yeah, we
Why
can do peak
selected
exploratory
specifically?
flow. Yeah, peak
Yes.
exploratory flow we can do to differentiate between bronchial asthma or chronic obstructive disease or restricted disease, I believe. So this case, we have to first diagnose whether it is bronchial asthma. It is more likely, it could be bronchial asthma. So we have to, I mean, if it is bronchial asthma, it is reversible dilation of the bronchio airways after
Mhm.
a bronchodilator.
But
So
that is in the
methacholine challenge.
symptomatic patient. That is in the symptomatic patient, right? So if some
Yes,
symptomatic patient comes to you with breathlessness, like it comes, right? Then you what you do? First do
yes,
the peak expiratory flow, check it is 50%. Example, right? After giving
yes,
bronchodilated beta 2 agonist, it is 80%, means improvement. Means there was
yes,
some kind of airway obstruction, right? That is in
yes,
symptomatic patient. This patient is
yes,
asymptomatic patient. So here you need to stimulate. First you want to do the bronchospasm because this patient is normal, right? This patient
yes,
peak expiratory flow could be normal, so you cannot diagnose, right? With this, there is no much effect because bronchus is already relaxed. It is not a constricted. When it is constricted, you give this second B option, right? Give
Yes.
bronchodilator and check FEV1. It is not the case, right? DLCO is not helpful in this patient, right? So proper test is, it is a methacholine is a synthetic cholinergic synthetic, which is a methacholine stress test. So if you give methacholine, right, and if you see there is a reduced in forced expiratory volume in 1 second is more than 20, it confirms the diagnosis, especially in asymptomatic patient, because whatever the test you do, everything is normal, right? With or without bronchodilator, same thing. With or without anything, peak expiratory flow will be said. Now his airway is open, everything is fine. Chest is clear, chest is normal. He denies no any medication. He currently feel well. He has no breathlessness. Respiratory rate not mentioned but normal. So in a asymptomatic patient, you give this stress test, 20% reduction, more than 20% reduction in FEV1, use methacholine test, confirms the bronchial asthma, right? So that's it. This is what the thing is. So another homework is the bronchial asthma. You need to know what is FEV1. What happens in bronchial asthma? Confirmed case of bronchial asthma, acute exacerbation. What happens, right, to FEV1 and FVC? Ratio is normal, increase or decrease? One question. Restrictive lung disease, interstitial pulmonary fibrosis. What happens to FEV1 by FVC? Increase, decrease or normal? So in asthma, anyone wants to answer what happens to FEV1, FVC? Normal, increase or decrease? This is exam question. Write down.
Normal or increased, sir.
Sorry?
Decrease.
Reduced.
Reduce, obviously reduce, right? Force expiratory volume in 1 second in asthma, right? It reduced. And with the restrictive lung disease, what's the result here?
Almost same restrictive disease.
Right, same, or it could be little high, right? It could be high, but it is reduced in obstructive airway disease. So your homework is how you diagnose bronchial asthma. Number one, write down how you interpret FEV1 by FVC in obstructive as well as restrictive lung disease. Second question in exam, right? One is diagnosis, second is FEV1, FVC, obstructive, restrictive, and treatment. When you use short acting beta agonist, when you use LABA, long acting beta agonist, when you use the steroid, right? These are the exam high yield question, and status asthmaticus as well.
Excuse me, sir.
Status
So if
asthmaticus.
we, so if we
Yes.
have spirometry in the option here, then
Yes.
spirometry as an option here, then okay, is that okay to use it in an asymptomatic patient? Or that is also too symptomatic?
Usually not, doctor. Usually not, because in asymptomatic patient, right, everything will be normal. So pulmonary function test or spirometry will also come as a normal. So you need to do something which stimulates the airway, which constrict the airway, right? Then you can confirm that okay, fine, right? This is the problem. You understand? So in a normal patient
Okay,
like
sir.
you and me, if you do the pulmonary function test, right, it is usually normal. It's usually normal. Fine. So these are the high yield points. I told you already what you need to work on yourself at home. So this is what the thing is. More than 20% reduction in FEV1 with use of methacholine, right? When a patient is currently asymptomatic, it is less likely to find increase in FEV1 with short acting beta agonist, as I told you, right? So this is what the base test is. Why not the chest X-ray? Because it does not show anything more than hyperinflation, so it's not good test. And ABG and PEF, peak expiratory flow, helpful when the patient in acute exacerbation, which is not the case here. So it is not much helpful. That's it. So this is what the various things is. I try to post it on the thing. So I will share these things with you. Right. So this is what the test is. The methacholine challenge test, bronchial challenge test. Right. Methacholine test, patient with suspected airway hyperresponsiveness. That is the indication of doing this. Suspected case, not a confirmed case, suspected case, right? So interpretation, as I told you, more than 20% reduction. That's all. Next questions in front of your screen. Little infective, come drug, come pulmonology. Three knowledge will be checked. Your infectious knowledge will be checked. Your pulmonology knowledge will be checked. Your HIV knowledge will also be checked. So a lot of subject in one question. HIV positive Afro-American man admitted with a history of dyspnea, dry cough, high LDH, PaO2 of 65. He started on sulfamethoxazole and trimethoprim and prednisone. On the third day of the hospital, he developed severe rash and neutropenia. He has anemia and there is a bite cells on the peripheral smear. What is the most appropriate next step in the management of this patient? Stop TMP SMX, that is trimethoprim sulfamethoxazole, begin antiretroviral therapy or anti-HIV therapy because patient is HIV. Switch TMP SMX to intravenous pentamidine. Switch TMP SMX to aerosol therapy. Switch TMP SMX to clindamycin and primaquine. Very interesting question. Yes, Dr. Nazis, your comment.
So first stop Bactrim.
So, okay. So I'll discuss with you. Are you okay with the discussion with me? Dr. Nazis, are you okay? Yes or no?
Yeah, sir, I'm okay, but I'm just
You are in OPD. That is
not
why I'm asking.
sure about the answer.
Yeah, so that is what the learning. If you discuss, then you never forget in lifetime. So what is the diagnosis here?
No, sir.
Take your time, na. You think, meanwhile, I'll go to the Dr. Seema Sultan. What's the answer, Dr. Seema Sultan? What's your answer?
Diagnosis.
Dr. Seema, are you there in the class?
So there is an anemia hemolysis due to the drug reaction. Can be
Fine. So you are Dr. Murshida? Yes, Ravi. What's the answer here, Dr. Ravi?
yes.
So the patient likely has
Can you keep your mics a little closer so I can listen well, if you don't mind?
deficiency and
Okay, your is a net
the
issue, no
patient
problem.
likely has a G6PD deficiency in which trimethoprim and sulfamethoxazole.
The patient
Okay,
having a
Yes, sir.
G6PD deficiency because of bite cell present.
Sir, this is a case of pneumocystis jirovecii in AIDS patient, and when the patient is given
yes, go ahead.
sulfamethoxazole
You are going absolutely well.
trimethoprim,
You
I
are
mean
going well.
antifolate.
Yes, fine, fair enough. So
So
let
this
me give you
patient
little clue. Yeah, so most of the
has
people are right. Yes,
neutropenia, and this is because of the
yes, you go ahead. I'm listening you, Dr. Shibilia. Fine. So this is HIV, right? It is a HIV
pneumocystis
positive. So
jirovecii,
yeah,
PCP, yes, HIV.
wonderful, wonderful. So this patient is HIV, right?
So this patient,
What's the history? Yes.
the patient, yeah, suggestive of pneumocystis,
Yeah, that's got it. Your
pneumocystis
answer, I got
jirovecii,
it. PCP. Fair enough.
PCP.
So this patient has HIV.
Yeah.
Now this has a
So this patient has, and the, yes,
dry cough,
yeah, and the treatment of choice is, yeah,
high
dry
LDH.
cough, raised LDH, and then count will be very less. CD4 count will be very less for this patient, and this patient drug of choice is trimethoprim sulfamethoxazole, but the sulfamethoxazole has a side effect that it will disturb the it is antifolate, folic acid antifolate FHR reductase inhibitor. So
Excellent.
yeah, so
Fair enough.
it
Excellent.
will bring neutropenia.
Wonderful. Very wonderful. Now
Thank
let's
you.
dissect these questions. Wonderful explanation by Dr. Chibila. So this patient has HIV. We go each and every word. Admitted now. Now after admission, what is the complaint? Dry cough, dyspnea, high LDH. This is the this supposed to be 75 to 100 for your knowledge. Arterial gradient of oxygen is 75 to 100. So now this patient has HIV, developed this. This is classical for your knowledge. This is classical of PCP, pneumocystis carinii pneumonia, which is an opportunistic infection when usually the CD counts are less than 200 or so. We start the PCP prophylaxis before it develops, right? This is already presented with this, right? So what they have done, so this HIV patient suspecting PCP by the sign and symptoms, they started on this two drug with steroid, right? Steroid. What happens on the third day of the hospital? Severe rash and neutropenia. So this is severe. This is started after admission. They had started this for PCP treatment. So this is a side effect. Neutropenia and rash is because of this. Neutropenia and rash because of this. What happens next? That is important. He has anemia. He has a white cells on the peripheral smear. So another anemia and white cell. It is the reason of anemia and white cell, right? Could be some kind of, this is a sign of hemolysis. What causes the hemolysis? This drug can cause hemolysis. When it causes, usually in case of Dr. Ravi told G6PD deficiency. So they have not mentioned, but you need to think in that way, right? So this patient has a likely G6PD deficiency. They have started, right? And in because of this, there is a hemolysis. So hemoglobin is also fall. That is anemia. And because of hemolysis, there is a bite cell on the peripheral smear, right? Now let's go to the questions. So we completely dissected this question. HIV positive, presented with the respiratory symptoms, suspected PCP, started on prophylaxis, because of drug developed something, and because of deficiency developed something. Now what you want to do? So now Dr. Nazis, tell me, is stopping the sulfamethoxazole and trimethoprim solve our problem? If you stop this drug, then how you gonna treat the PCP? Tell me, number one. Nazish.
Sir, it is gonna solve our problem, obviously.
So that means
But next step,
stopping will not solve the problem. You need to add something which acts against the PCP, right? Because for PCP you started the standard
yes,
treatment, sulfamethoxazole, trimethoprim. Unfortunately, toxicity developed,
yes, sir.
something went wrong. So right. So if you stop this one drug, you need to start some anti-PCP drug. Am I right or wrong? Yes or no? Tell me at least yes or no.
Yes,
Right. So what
yes,
you
sir.
so just stopping will not solve the problem. So those who say, for example, I'll give you the example. Patient has a malaria example. You started the, like, chloroquine you started for this patient malaria. He also developed malaria, very bad rash, neutropenia, pancytopenia. So you stop the chloroquine. If you stop the chloroquine, then how the malaria will go? Then you need to add something: sulfaquine, maploquine, arteristinate, artemether, falsigo. There are hundreds of agents which can be used, right?
Yes,
So
yes,
stopping the drug in any patient in case of these things, just stopping the drug will not solve the problem. Stopping the drug, what it helps, right? Probably the rash will go, probably the neutropenia will go, probably hemolysis will go. But what will you do for the PCP pneumonia then? He will die because of PCP pneumonia, isn't it? So you
yeah.
need to start anti-PCP treatment. So now C, B, C, D, or E, which is the best option? Anyone wants to make any comment?
The
It's
first
open.
option is pentamidine. Pentamidine is the first
Pentamidine.
option.
Excellent. So now the answer, being antiretroviral therapy is not immediately important. Let me give you all the reason. Because when patient is in infection, patient is not well, patient has a septicemia, right? Patient has some kind of immune things. This immune reconstitution syndrome will start in this patient. It will start immediately. So what you do? First treat the PCP pneumonia, let it be settled, and then start HAART, highly active antiretroviral therapy, or shortly ART, antiretroviral therapy, right? So this is not appropriate and it will not affect on the PCP, right? It affects on the HIV, not on PCP. What is the active problem now is the PCP, right? So it is not right option now. After after PCP correction, yes, definitely you need to add this, but not now, right? Switching to the switching TMP SMX to aerosol, it is not as effective as other agent. And let me tell you, this clindamycin and primaquine are more powerful than pentamidine. Then why we want to use pentamidine? Anybody wants to comment on this? If you go and review the literature, For PCP, clindamycin and primaquine is more potent than pentamidine. The reason is that again primaquine in G6PD deficiency cause hemolysis. So you want to avoid the primaquine, and that is why primaquine is also not good, because if it is no G6PD deficiency, if no bite cell, no anemia, then this could be drug. But if it is this in this vignity, this is the closest answer is to switch to the pentamidine. That's all from my side. Any query? Any questions, Nazish?
No, sir, I'm clear.
Any questions to anybody in this board? Is that clear, everyone? Yes or no? Tell me at least yes or no.
Yes, sir.
Wonderful. So this is what the explanation. This is how you need to do practice at home. You don't need to mug up. If this question comes, we'll do pentamidine. So they will change the question. You need to understand why bite cell, why anemia, why neutropenia, why this, why that, right? Everything is there in the questions. I did not added something from my side. It's all in the question. Correct answer is to switch to the pentamidine. RAS is most common neutropenia and myelosuppression from sulfamethoxazole and trimethoprim. Although clindamycin, primaquine, as I told you, clear cut, right? As I told you, right? What I told you, that although clindamycin and primaquine has more efficacy than pentamidine, but patient we are suspecting G6PD deficiency and primaquine is contraindicated. That is why it is not a drug of choice. And bite cells are suggestive of G6PD deficiency. So, and for active disease, intravenous pentamidine is used, not the aerosol, maybe more powerful and efficacy, right? Starting antiretroviral therapy is the right choice eventually after treatment of PCP. So that's it. That was the explanation here given on this slide. So I'll switch to the next question if everyone is agree with my explanation. Should I go ahead? Yes or no?
Yes, sir.
Wonderful.
Yes, sir.
Wonderful. Next, bear with me for more few questions. 55-year-old man who has never smoked with no past medical history has been diagnosed with the right basal community acquired pneumonia. There are minimal changes on his chest X-ray and blood reveals a neutrophil count of 8.2 or 8,200 per cubic millimeter, which is normal. 4 to 10 is normal. He has 8.2. For your knowledge, CRP is of 15, little high, not very bad. He has a no drug allergy, although he has a productive cough of green color or green sputum. His respiratory rate is 16, oxygen saturation is 97% at room air and temperature is 37.4. You are asked to place him on treatment. Which of the following treatment option would be the appropriate for this patient? Oral amoxicillin, oral erythromycin, intravenous ertapenem with macrolide like clarithromycin or azithromycin, or intravenous tazocine. What is the diagnosis? What is the investigation? What is the treatment?
Okay, because cytoplasm is fluctuating between 16.
Let's try to other doctors. Just wait.
The place in Montreal, which is the following options should share. Paritram macrolide.
Dr. Sharma, Dr. Manjit Singh, what's your answer? Sat Sri Akal.
B or B?
सत श्री अकाल सर.
क्या है जनाब, बताइए इसका आंसर.
The oral amoxicillin.
Yes, E.
Oral amoxicillin, who told?
So,
iPhone.
yes, sir, Beanish, sir.
Sorry.
So we have to give, sir, oral amoxicillin, sir, we give 1 gram 3 times a day. So we also give
let's
doxycycline
discuss
also.
with this you. So what's your diagnosis here? Let's go one by one. I don't want to break my step. A, 1, 2, 3. What's your diagnosis here? You can read the scenario. I'm not in hurry. What do you think? What could be the diagnosis? It is given there. Clear cut given there.
Sir, community acquired pneumonia.
Wonderful. Excellent. So community acquired pneumonia. So we come to the conclusion that we are dealing with some kind of community acquired pneumonia. Now, Dr. Banish, tell me, what is the CURB score for this patient? CURB, CURB 65 for this patient. You count. You count.
What
is C? What is U? These all are questions in exam. In one question, we are solving 10 questions. So what is CURB 65? Any community acquired pneumonia, you must ask yourself what is a CURB 65. Without that, you cannot go and treat the patient. Yes. What is C stands for? What is U stands for? What is R?
Yes,
What
sir.
is B? It is 65. If you
So
don't know, you
C
tell me
is
you
for
don't know.
confusion. So
One minute,
U
one
is
minute.
for
Let
urea and blood
one minute.
urea nitrogen.
Let us finish one by one. C for what, doctor?
The confusion.
Confusion. Okay, fine. Confusion. U for
Urea.
urea.
Blood
R
urea
for
nitrogen. Respiratory rate.
respiratory rate. B for
Blood pressure. Systolic blood
blood
pressure.
pressure. Okay. And 65 is what? Pulse rate?
The age more than 65. Age more than or equal to 65.
Fair enough. So now you see all 5 criterias are there or not, and you tell me the score. What I put it here, 0 or 1 or 2. For C, what I'll put it. I want to check. I want to count the score now. I want to count the CURB 65 for this patient.
We cannot count CURB 65 because that doesn't give blood urea, blood pressure.
Yeah.
So see, doctor, just one tip. When there is a not given in scenario considered as a normal. When it is not
Okay,
given,
sir.
sugar is not given, means sugar is normal. If something IHD is there or not, it's not given, means there is no IHD for your knowledge, right? So now confusion, what I put it, the score here, 0, 1 or 2.
0.
Benish, you answer 0. Urea,
Yes, sir, 0.
0.
respiratory rate,
0.
0.
All
Blood
0.
pressure, 0, 1, 2.
0.
0.
0.
Age, 0, 1, 2.
Less than 55.
0.
So for this patient, CURB score is 0, right?
Mhm.
So how you gonna calculate? Those who don't know CURB 65, let me tell you. So those patients who have community acquired pneumonia, you need to always write down the CURB score. CURB score is like confusion related with the brain. So in pneumonia, brain is involved or CNS involved, not involved. If patient is confused, unconscious, score is 1, right? So there are minimal score is 0, maximum score is 1. Just to confuse you, I am telling you 2 as well. So there is nothing like 2, just for your knowledge. If confusion is not there, 0, confusion is there or unconscious, 1. Urea, right? Urea or BU and urea nitrogen, right? If it is more than, or creatinine, right? Urea is more than 6 or 7. I exactly, sorry to forget, 6 or 7, right? It is there, then it is 1, otherwise 0. So here 0. Respiratory rate more than 30, it is 1, less than 30, 0. Here a respiratory rate is 16, so 0. Blood pressure not given means normal, then it is a 0. If blood pressure is low, low means less than 90 systolic blood pressure, it is 1. So here not given means normal, so 0. And age is more than 65, it is 1. More than or equal to less than 65 is 0. So here the CURB 65 score, if you count CURB 65, 0. Why you want to know that? Yes, Dr. Banish, tell me. If score 0 is what? 1 is what? 2 is what? 3 is what? 4 is what? 5 is what? Tell me. Why you want to know the CURB 65? What's the advantage of counting the CURB 65? How you gonna change the management in the CURB 65?
Determines the mode of OP
I
treatment.
want to hear from Banish
So
only.
we will get to know that if the person is suitable for home treatment, the risk of death, or if
So,
the person needs a hospital treatment.
so score why we want to know. One is to hospitalize or not hospitalize, right?
So for
What
0,
you
there's a low risk of death. If the CURB 65 score is 0, so there is no low risk of death. So
fine. So here you classify like this only. 0 and 1. 0
Less
and
than
1. 0 means this. Maximum is 5. 0, 1, 2. Rather you can say low risk, right? This is overlapping. 2 and 3 is overlapping. But just for your knowledge, just you need to understand. And 4 and 5th is little high risk.
yes.
4 or 5. So I can categorize this CURB score in that way, simpler way, mild, moderate, or severe. This is one way to classify, or grade 1, or this is grade 1, grade 2, grade 3, just for your knowledge. All right. Why it is important? Because this grade 1 or mild category, the treatment is outpatient, OPD, outpatient department, with some kind of outpatient means oral, obviously, outpatient. 2 and 3, you just need to see along with the score how is the clinical condition of the patient. If it is not toxic, otherwise stable, otherwise fine, OPD versus IPD, it's your call, right? And 4 and 5, they need ICU
Yes, like
hospitalization,
ICU.
ICU, ideally ICU, right? Why? Here the mortality in OPD is less than 5%. Here mortality is 5 to 10%, and here close to
30.
20%. So you need to categorize which are the high risk patient. This is other way, low risk, intermediate risk, high risk. There are a lot of way to this, but I want to give you the concept. So you need to know the score of the patient on depends on the score of the patient. First of all, what you gonna take decision, Dr. Banish, whether to admit in OPD, IPD or ICU, number one, right? What the
Yes.
mortality rate you need to know, right? Because you cannot say 5 or 4 patient, okay, you go home, take amoxicillin oral erythromycin, you will be fine. He will die in 2 days. You understand? It's a high risk patient. You can't keep. He is a hypertension. He has a confusion. He has a low blood pressure. He has high respiratory rate. He may die in respiratory failure in 2 or 3 days. So you can't let them go home without explaining the things properly, right? So this is why the cup 65 comes in the picture, right? So you must know each and everything. Anybody comes to you in your OPD, even though score is 0, you must know. Now, so this patient score is 0. This is a very low risk patient, right? Less than 5% or even less mortality. You can treat in the OPD, you can give some oral drug. That's it. This is what the answer is, right? So now tell me, Dr. Banish, which could be the most commonest organism? So now we see score is 0 of this patient, right? You want to start some
Yes, sir.
treatment. I'm asking you, what could be the most common organism for this community acquired pneumonia in India?
So it is Streptococcus pneumoniae.
Streptococcus pneumoniae. Is it typical or atypical? Second question.
So
Or
it
tell
is
me what are the atypical organisms in pneumonia? This all are questions. We'll discuss everything.
atypical are chlamydia and mycoplasma.
Chlamydia, mycoplasma,
Yeah,
Legionella,
Streptococcus.
Legionella.
Legionella, COVID-19, these all are atypical. Is that clear?
Yes,
Yes or
sir.
no?
Yes, sir.
Right. Now tell me what are the typical then?
The strepto and Haemophilus influenzae.
Okay, fine, fair enough. Streptococcus. Staphylococcus, if I can tell you, Staphylococcus is which? Typical or atypical?
So Staphylo is
So it's a hospital-acquired pneumonia, no? In that case, staphylococcus.
So homework, write down homework. After my class, go and read, don't waste time.
The
Curve 65,
Staphylococcus typical organism.
curve
Typical
65, those who,
staphylococcus.
so it is
Yes.
atypical. Staphylococcus is atypical.
No, it's not a
so send me the literature. Send me the literature, and that is sent in the group, not to me personally. Why? Because everybody will learn. That is the reason. So one
Yes, sir.
homework is to those who don't know what is curve 65, again go and read it in chapter, clear cut given. I told you completely, but still you read. Second thing is you need to know what is typical versus atypical. So it's a long list. What is typical? What is atypical? What are the organism in typical? What are organism in atypical? How you treat atypical? How you treat typical? This is second homework. Third homework. In pneumonia. In pneumonia, associated condition and organism. Example I'm giving you. COPD patients develop pneumonia. What is the commonest organism? Write down or take a picture of this.
Maxilla.
You never thought of this. I'm giving you absolutely high yield point what they ask in exam. Second patient is diabetic mellitus patient, develop pneumonia. What is organism? Alcoholic patient, right, develop pneumonia. What is commonest organism? Somebody living with the birds develop pneumonia. What is the organism? Somebody living with the animal develop pneumonia. What is the organism? Somebody is absolutely healthy patient develop pneumonia. What is the organism? Binis, you would like to try this?
So healthy person.
All healthy person. You pick up anything and answer me. This all are question in exam. Huh? I'm just trying to open up your mind.
So
Do you know Banish anyone?
streptococcus, sir.
The chlamydia city that for birds can be due to chlamydia
Chlamydia.
city.
Take a picture and see it. I'll give you the answer here right away. Don't worry. But you need to understand, right? So this is the slide. Common pathogen CAP, community acquired pneumonia, and their association. CAP and their association. First of all, COPD, I told you, likely is Haemophilus influenza. Recent viral infections, Staphylococcus. Alcoholism and diabetes, Klebsiella pneumoniae. Right? Poor dentitions, it's anaerobes. Obviously, anaerobes grow. Right? Young and healthy patients, Mycoplasma. Hoarseness present with the pneumonia, likely chlamydophila. Legionella with contaminated water. Birds, Chlamydia psittaci, and Coxilla is with the animal. That's it. This is what the high yield points, absolutely high yield points. So I told you it's from the book. It is nothing from out of the box, right? So, but you need to know. You need to know. You need to know. So go and mug up little chart. Do some exercise. Mug up this chart. Take a picture. Whatever you do, it's all from the books and all from our website. All questions is there uploaded in the same pattern on our website in mock test, practice paper, recalls, past paper. Everything is there. Nothing new I'm presenting to you, but I'm trying to give you the idea how you supposed to solve the questions and answer. That's it. So this is what the thing is. So here answer. What is the answer, Dr. Banish?
So for so
So now
amoxicillin.
this patient, 55-year male, curve score is 65, curve 65 score 0. He is absolutely stable. You are treating on OP patients. Probably you told me streptococcus. Now you want to give. So this is a curve score 65. So this is what the basic is, right? You don't need to, we don't need to be a Einstein, right? Intravenous gone. Score 0, you don't need any intravenous. Is that clear?
Yes.
Score 0, patient stable, moving, it's
Erythromycin.
fine. So either you need to decide between A and B. So
B, sir. A.
amoxicillin is a drug of choice. So again, go and read it bit more in detail. So from the history, we see the patient's CUP 65 0, putting him into a good prognostic category, right? From the list, amoxicillin A would be the preferred over erythromycin, as it covers the most of the organism, including Streptococcus pneumoniae, and it's the broad spectrum of action, while the macrolide will cover the atypical organism, right? So we want to use the most common one. Amoxicillin is the drug of choice. So depends on what you are thinking. So first, amoxicillin is the drug of choice. And this is what the basic things I would like to tell you very quickly, right? Because it is important. The infectious disease, whenever you solve any MCQ with the infectious disease, right? Radiology is not a right answer, right? Because when you are dealing with infectious disease, means you need to do some microbiological diagnosis. Microbiological. Radiology is not a good answer. Blood culture is positive only in just 5 to 15% of the cases of CAP, means 80% you don't get anything. You need to treat empirically. It is impossible to make specific diagnosis of the cause of pneumonia from the history and physical examination. Microbiology is there, but microbiology present in 5, 10, 20%, right? Many times cultures, all sputum, blood, blah, 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 all negative. Mycoplasma and chlamydophilia are rarely confirmed, but so they are empirically treated. And it is the most important sentence highlighted it by me in red. It is the severity of the disease, not the etiology, that drives the initial treatment. So how patient is critical in pneumonia. You don't know anything. No, when patient comes to you with fever, cough, blah blah blah, you are suspecting community acquired pneumonia. Tell me, what will you get the result in next 48 hours? You send everything. You send sputum culture, ESR, CBC, liver, renal, chest X-ray, blah blah, everything, whatever possible basic test you have done. Then you are not going to treat, Dr. Banish, or you will going to treat, or you wait for the result.
I'm going to treat. So we are going to
treat.
treat. Yes, sir.
Yeah, so that is what it calls. It's empiric treatment. You don't know what the organism is there. You just suspected pneumonia. Likely cup score 0, give azithromycin, this amoxicillin. That's it.
Yes, sir.
You understand? So most of the pneumonia is treated empirically. Once the specific organism will come or grow, then you switch to this specific treatment. Otherwise, most of the time, it's like tuberculosis, meningitis, right? You are suspecting TBM. So you are giving the empiric antibiotic. Once the culture comes, then you switch to other things. This is how we treat clinical in patients as well. Some patient high grade fever, I send the blood culture. I'm suspecting septicemia. Antibiotic I started is like piperacillin tazobactam, not working. I change to ceftriaxone, not working. I'm confused what antibiotic to use. I send the culture, right? So culture is taking 48 hours. Right? What I have to do? I have to treat the patient as per the clinical dignity of the patients. Right? That's all. So this is what the thing is. So there are a lot more things to discuss in pneumonia. It's a quite vast topic. So, but you need to know pneumonia is absolutely high yield point. So homework, again homework, like gestational diabetes mellitus, drug, midazolam versus that, right? So this is also, again, you need to know the all organism. Probably you forget now again, right? But you need to know with the bird, with the animal, with the recent viral infection, COPD, healthy individual, diabetic, alcoholic, blah blah, right? So you need to mug up the things, right, with these things. So I'll just switch to the next questions. Gleason score is used in which of the following condition? One liner, not much brain to apply, but you need to know. Hepatocellular carcinoma, pancreatic carcinoma, prostate carcinoma, cervical carcinoma, colon cancer. None of the above. It is not used for above this.
So prostate cancer.
Okay, let's see what other experts are saying. Yes, one answer is prostate. One is breast. What else? Your answer, Dr. Nasrin, is pancreatic cancer. Yes or no?
Yes, sir.
So, yes, tell me. So, you use in pancreatic cancer, what is Gleason score? Can you describe, Dr. Nasrin, what is a Gleason score? How you describe, how you do?
Sir, I come across I remember something like pancreatic asthma reasons. Full explanation I'm not able to say, but
Fair
some
enough.
of it.
Fair enough. Fair enough. Fair enough. Yes, anyone wants to try this question?
So it's prostatic cancer.
Okay,
Gleason.
let's discuss. Let's discuss prostatic cancer. You Binish, right? iPhone is
Yes.
Binish.
Yes, yes.
Wonderful. Next time, change your name.
Okay, sir.
So I can know because there are a lot of iPhone in the class 25, 30 doctors. So anyway, so I'll speak by name. That's good. So what is Gleason score then, Dr. Banish? Tell me, what is Gleason score
So
or
it is
Gleason's
used,
grading score?
the Gleason scoring system is used for prostate cancer. If it is less than 6, then Gleason grade is 1, and the cell pattern in the cancer would be there would be small uniform glands. And if it is 7, that is 3 plus 4, then there will be more stroma. And if it's 7, 4 plus 3, then there will be infiltrative margins. And if it is 8, that is grade 4, there would be irregular masses. And if it is 9 or 10, that is grade 5, there is lack of gland formation.
Fine, fair enough. You explained very well. So what's the why you want to know the grade 1, 2, 3, 4, 5? What is grade 1? Which grade has the highest risk? What is the lowest grade? What is the highest grade? 1 is good or 5 is good? If I say patient of prostate
Yes,
cancer
sir.
with Gleason score of grade 1 and another patient Gleason score of grade 5, which is a bad one? 1 is bad or 5 is bad?
So Gleason score 6 is considered a low grade. Medium grade is 7, and sir, 8 is high grade cancer. So Gleason score of 10 is bad.
Yeah, so this is score. This is score, right?
Yes, sir.
One is score and one is a grade, right?
Yes,
So
sir.
I'm talking here about grade, not the score. Score is write down as a 6, 7, 8, 9, 10, blah blah, right? 1 to 10, anything. 2 to 10.
Yes, sir.
So grade is different and score is different. So I'm talking about grade. So if I say that prostate cancer grade 5 and one patient has prostate cancer grade 1, which one is bad? So let me give to the basic things 1 minute. So people, all other people will also get involved. Let me show you. This picture is self-explanatory. If you understand this picture, everything is crystal clear. I got it very hardly by reading lots of book. I was looking for book. I got it from one book while preparing my lecture. So Gleason pattern. This is pattern, right? This is pattern. Say for example, this is one pattern. This is second pattern. This is third pattern. This is fourth pattern, and this is fifth pattern. This all pattern is under microscope. Huh? Let me tell you, microscope. Am I right, Barish?
Yes, sir.
This is under microscope. This is a routine. Just I mean, we are trying to grade. So there is a prostate gland. So you must be knowing this is a bladder, right? This is ureter, right? Above ureter there is a kidney, right? This is a neck of the bladder, and below that there is a gland called as a prostate, and in between there is a prostatic urethra past, and this is a glans penis. This is how just the things, right? So when there is a prostate problem or we are suspecting prostate CA or there is an increase significant PSA, we are worried about prostate cancer. Am I right or wrong?
Yes, sir.
Right. So we do a biopsy of the prostate. The biopsy is called as a transrectal. First we do TRUS. Have you heard of TRUS?
Yes,
Have
sir.
you heard of TRUS? TRUS is transrectal ultrasound.
Yes, sir.
Transrectal ultrasound and then transrectal biopsy. Why the transrectal? Because the prostate is very close to the rectum, right? So it's easy, more sensitive, specific, and easy to do as well, right? So you do right transrectal ultrasound, you see, and wherever there is a lesion or swelling or lump or decrease the mucous membrane regularity, you can take a random biopsy as well or direct biopsy from that as well, right? So when you do the biopsy and see under the microscope, right, they have made some grading system, and this is the name of the person Gleason who did it. So 1, 2, 3, 4, 5, right? So this is a recognizable gland. They had given the recognizable gland. This is few recognizable. So this white are recognizable. Then this all change, blue change. Here there is almost no white. Binis, are you getting me?
Yes, sir.
All white is good here. Here very little less white glands, which is a prostatic glandular tissue, and here almost I cannot see any white gland, right? So this is the bad one. So recognizable gland, few recognizable gland, no recognizable, right? So this is they have mentioned. If you see under microscope, give the score 1, 2, 3. If you see little and few, and if you not see at all, give the score 5, right? Now on this is normal, right? If you see, you give the grade like this, right? So now lowest score is what? And now how they did the score? Most common pattern plus second most common pattern. So you have examined a prostatic structure, say for example, right? Have right. So this is a complete prostate biopsy picture. Example, right? Here you see, say for example, you see looks like this. Highest is this. So here the score is 6. Second most common pattern looks like this, right? So this is 2. So 2 plus 3 is score 5. This is called score. So this is a score. Benis, are you getting me?
Yes, sir.
Right? So what they have classified less than 6, either 1 plus 1, 1 plus 2, 1 plus 3, 3 plus 1, 3 plus 2, 3 plus 3. These all are the possibilities, isn't it? Yes or no?
Yes, yes, sir.
Right? So maximum 6 or less than 6, right? Then grade. This is grade. This is score. So don't get confused. This is score. 1 to 10 is a score. And here grade. This is grade. This is score. Right? So we need to calculate the score like this. So if you, I will share one of my patient's biopsy report of Gleason score in the group. So you get to know that, okay, fine, how it's reported. So they report like this. Gleason score is 5, grade is 1. Gleason score up to 6, grade 1. 7, grade 2. Third, sorry, this pattern 3, this 4, and this 5. So 4 and 5, obviously this is very bad. The most bad is 5, the most good is a 1, because you can able to differentiate, right? So when the grades are increasing, any cancer, grade 1, grade 2, grade 3, 4, 5, in general principle, grade 1 is a well differentiated, right? Mildly differentiated, moderately differentiated, poorly differentiated, or undifferentiated. This is how in general, we classify. So undifferentiated is the worst one, well differentiated, it's a good one. This applicable to all tissues under microscope for the grading system. So here they are mentioning the Gleason score, right? So Gleason score is developed for the prostate cancer. Number one, there is a score system, there is a grade system. Higher the score, bad the things. Higher the grade, bad the things, right? So if the score is high, bad. If the grade is high, it is bad, right? So this is how it is done for years and years, right? So Gleason score of 8, 9, 10 is absolutely high risk. So in general, if I want to tell this patient or categorize this, I can say this is mild, this is moderate, this is severe. In general, just for your understanding. So 4 and 5 is very bad. Anyway, cancer is bad at all, even it is grade 1 or score 2 or whatever the score. But just for the prognostication, we need to know what is what. Banish, is that clear? Yes or no?
Yes, sir. Yes, sir.
All clear?
Yes, sir.
Means concept clear?
Yes, sir.
Wonderful. Now, why we want to know the Gleason score? Let's comes to the clinical things. What I'm looking in my patients every time, and I'm counting the Gleason score. Why I want to count the Gleason score? Gleason score less than 6. See, the 5-year survival rate is after radical prostatectomy. If I did an operation 5 years later, if the score is less than 6, 96% will live 5 years or more. So excellent prognosis. And see the Gleason score of 9 and 10. Only just here, 96 is mine. Close to 100%, I can say. And here, just 25% will survive more than 5 years. Means within 5 years, they will die. And 5 years or 5 years plus, they almost close to 95 to 100% patient will live. So less the Gleason score, good the prognosis. Higher the Gleason score, poor the prognosis. Banish.
Yes, sir.
Is that clear?
Yes, sir.
Great. So that's the thing is, right? So it is not used for the pancreatic cancer. It's not used for the cervical, breast, ovary. Just to confuse you, I created these questions today, right? So answer of this question is prostate cancer. Gleason score is prostate cancer. Gleason score and grade. Don't confuse. Score 1 to 10, grade 1 to 5 are used to grade the metastatic potential of the prostatic adenocarcinoma. Higher the Gleason score, higher the Gleason's grade, they have high intensity, high chances of spreading or to the metastasize to the other parts of the body. Another question, which is the number one site? Which is the number one site for the prostate cancers to spread?
Bone.
Liver, lung, bone, brain.
Bone, sir.
Prostate cancer spreads. What you see in a maximum number of patients, what is the first commonest metastatic site in prostate cancer?
Bone.
Banish.
So
Excellent.
bones.
Bone. Excellent. Bones. Bones. Second question, which bone? Anyone? Which bone? Ribs, skull, humerus, femoral.
Spinal bone, spine.
Spine and pelvis. Excellent.
So
Third
ribs also.
question. Ribs also, but first is spine and then spine pelvis is the commonest. They sometimes present with the cord compressions as well. I handle many emergencies in my clinic, and still we are getting it. Many cord compression. It's an acute emergency, especially lung cancer, prostate cancer, renal cell carcinoma. They very commonly spread to spine and bone and pelvis. So many a times they comes with a cord compression, cord equina syndrome, paraplegia, both lower limb, urinary retention. We need to give immediately the steroid and later on radiation versus surgical decompression. That's the treatment. Anyway, so so that's the thing. And last questions for this: how how they spreads to the bone from prostate? How they spreads to the bone? How they spreads from prostate to the bones or vertebrae or pelvis? How do they spread? Anyone? Anyway, so that's your homework. That's your homework, right? Prostatic plexus, Nasrin doctor told. I want to know the name of that prostatic plexus. Hematogenous mats, but which channel, which route? There is a specific name of the channel or route. Go and read it.
Santorni's.
Oh, sorry.
The Santorni's plexus.
Jabardast. Javed Qureshi. Batson plexus. I'm very glad, very happy. This is the name of the things, Batson. So I'm very glad we
Yes,
have very brilliant batch. So Batson's plexus is the route by which it goes from the prostate to the bones. But those who don't know, go and read it. So I think I conclude I'm speaking for 94 minutes unbeaten. Hopefully you enjoy my class. We have few questions to discuss, but hopefully I think we'll discuss in the next meeting. Right. So thank you very much all for your kind presence and attention and interacting with me. So I would like to, before ending up my session, would like to have very quick feedback as usual, just to how we can improve more this coaching classes. How did you enjoy my class and what you learned something new in the class, please? Anyone? I would be glad. Open. Even old students can also give, not just new, but I would like to hear from new more because how they expected the class and what is the real thing, how they expected. And
Sir, I'd like to give a feedback that, sometimes the answers, because of repetitive doing the MCQs, you think you know the answer and the answer is correct. But with you, I think we're kind of forced to brainstorm, which opens up, those small closed windows of the brain. So I think it's not only knowing the correct answer, which is of course important, but also to understand the concept clearly about the diagnosis as a triangle you make. So I think that really helps in clearing a lot of concepts and helping us to solve like 10 more questions.
that's correct, doctor. So basically our job is not just to mug up the answer. It's absolutely right. That is why I'm repeatedly telling all the patients, oh sorry, all the doctors, that okay, while they are, I mean, while even in our coaching we do the same thing. So right, this is just the one glimpse of the class. But anyway, I mean, if you think of the questions properly, because in one question like asthma we had 10 questions, right? In gestational diabetes we have 10 questions. In gleason and prostate we have 10 questions. So I mean, it's what important you, while you doing the practice things, right? You try to concentrate on the all three things: diagnosis, investigation, treatment. This is minimum. I'm not telling you what's the prognosis, what is the causative organism, what is the pathogen physiology or pathogen. It's not required now. But being a clinician, what they exactly ask you in your exam is this: either three things: diagnosis, investigation, treatment. So now onwards, when you do, even though ask the diagnosis, you consider thing Legionella, you diagnose Legionella. But you need to know no, what is the cause of Legionella pneumonia. You need to know at least what antibiotic you give, because this all will come in the exam. That's it. They won't ask you high five, but we are probably we are not well prepared, and we don't know what exactly we need to do. That we will guide you anyway. So thank you very much for your kind feedback. Any other feedback very quickly, Dr. Banish? Anything you learned new? Dr. Ravi, Dr. Nasreen, Dr. Nazish, anything? Naveed, Shibila?
So it will be great if we can discuss direct exam papers. I mean, once in a while, once in a month.
Sorry, sir.
Recent exam papers. Recent exam papers.
We are uploading, sir, on the mock test. This is all the paper. I'm doing extremely hard work, sir, honestly speaking, and uploading on the website. This mock test, if you get more than 75%, I can guarantee you there is no scope for failure, right? But how did you get to know whether you are getting 75 or 65 or 55 or 85 after giving the mock test, which people are not doing it? This is what I'm observing on the website for many times. I mean, At least we started for last 6 months the dedicated mock test. We designed them a separate dedicated this department at no cost. It's only in your package only, nothing new, no cost. It's cost effective. So anyway, try to do the maximum mock test. We did a mock test. No? I did not took only gynec, surgery, right? We did hematology, lot of various pulmonology, HIV, infectious, lot of things we covered in one thing. So you need to do.
Sir, I want to say something.
Yes, please.
Sir, I was preparing for the hard exam for last 4 months, and I was studying the theory, but I did not know where to find the exact PROMETRIC MCQs.
Okay.
So the kind of questions they ask us in our academy, they are very different from these questions. And today I got to know a different approach to solving the questions, the triad of investigation, diagnosis, and treatment. The basic three
Yeah,
things.
because
They sometimes lead us to so much complexity that we forget these three basic things, and we waste time on studying the things that are not gonna be asked in the exam. So
very
I
good.
want to thank you for like giving me the right direction, and now I kind of know which points to cater in a whole topic in a short time. Thank you so much
Recently,
for
one
that.
of you're welcome. If you are appearing for hard, one of our doctor recently cracked, so she will share the experience with you.
Yes,
Just
sir. Yes, sir.
touch
I've
with
talked to
me.
her.
Yeah, so Dr. Saba, because this all, see, she used the same thing. She did not use out of the blue or something, I mean, some extraordinary thing. What we discussed, she did it in 1 month only or 5 weeks only,
Yeah.
just right. She did not
Yes,
crack
sir.
in first attempt, right? Because she was reading, but she doesn't know how to read, what to read. I try to make you how to read, what to read, where to concentrate, what are the key points, right? So our job is not just to answer A, but you need to do practice from now onwards. Why not B? Why not C? Why not D? Why not E? You understand? So when you try
Yes,
to
sir.
understand why not B, C, D, E, then your theory would be powerful. Your logic would be
Yes.
powerful. You understand? Right? So our
Yes, sir.
job is not just to
Absolutely.
mug up the answer. You need to exclude other things as well. That makes real learning by my sense.
Yes, sir.
Wonderful. Thank you very much
Thank
for
you,
your
sir.
feedback. Anyone else? Last, Dr. Javed Qureshi, anyone, anything you want to make a comment?
No, sir. It's basically so far so good, sir. But my only one submission is if we can cater it, sir. Can we do a bit more questions because we have already spent 90 minutes? Sir, can we
Yes, sir.
go try to attempt 12 to 15 questions in a session because it's
It's
a
possible,
beautiful.
sir. For me, sir, 50 question is also possible. But
Sir,
probably what I observed of last many years of coaching, I deliver more than thousands of lectures so far,
sir,
right? But
sir,
if I go fast, if I don't tell you or explain you bit properly, then probably you just know the answer. You will not get the logic or concept. Here you got all concepts, right? Gleason score, now you got a concept. You read by your own 100 times. Even being a medical oncologist, it took a lot of time for me to understand what is Gleason score, even though I'm a
right, sir,
DNB oncologist. So
sir.
trying to understand the thing is more important, I think, in this exam. And if you do
Sir,
this
plus
practice for
we,
2 months is enough for anyone. 2 months you
yeah,
prepare properly, and 1 month you absolutely bombard on the mock test. Absolutely bombard on the mock test, right?
Right, sir,
And try
right,
to write down what your weakness. Write down your weakness. I don't know
yeah,
cystic fibrosis. I don't know acute versus chronic leukemia. I don't know Hodgkin's versus non-Hodgkin. Make a long list of the topics what you don't know. Prepare that. I can guarantee you. Give any exam. I guarantee. Open challenge. No scope for failure. But we are not probably that sincere. We are, I mean, just doing it, reading 550 question, 100 questions. We are happy end of the day. But we don't know what we gathered, what we catch, what we learn, what we, I mean, digested. You understand? So
right,
do
sir.
yeah.
sincere practice in that. I think that
Sir,
makes sense.
along with that, sir, from these 7 questions, we extracted almost like 20 to 30 questions.
That's what I'm trying to explain you, doctor, right? Otherwise, because they won't ask, the way questions I'm formatting. It is not
Yeah,
mandatory. They will ask what the question copy paste comes in picture.
yeah,
But if you
exactly.
understood the pneumonia, if you understood the HIV, if you understood sulfomethoxazole, grading, whatever they ask, I can challenge you, you will 100% answer. So what you need to do? You need to do at least 2 mock tests per week. So if you are preparing for 3 months, you are solving close to 12 to 15 mock tests, and that 12 to 15 mock test is close to 1200 questions. And
Yes.
1200 questions is all complex. If you just concentrate on your weakness part, 100% you will pass. It's just matter of maximum 3 months. I'm telling you, any doctors can easily crack with the proper timetable and planning in 3 months. If you need any help, call me directly later on. We'll discuss. We'll try to help you out. That's fine. No problem. But you need to be first sincere yourself, right? You need to concentrate on your weakness. You never write down what topics you don't know. And believe that same topic will come now. How you diagnose acute leukemia, it comes in the exam. How you diagnose hemolytic anemia, it comes in the exam. You don't know. You need to make a list subject wise that okay, 10 topics in gynec, 5 topics in vaccination schedule, you don't know, blah blah. That's it. This is the thing. So after end of the day, you get that okay, I need to do just 100 topics. Example, 100 topics, right? So just concentrate on 100 topics. Do it 5 topics or 10 topics a day. In 10 days or 20 days, you are working. Now, I'm also working. I'm working more than you. I'm working 12 hours in the hospital. I'm treating high-end treatments, all leukemia, lymphomas, myeloma, bone marrow transplant. I'm a busy guy. Still, I spare time. Na? I'm sincere enough. I'm not trying to praise myself, but can anyone tell me I had not taken even a single missed class on Sunday? It's not very easy, doctor. Absolutely
Yeah.
difficult. You try to take one lecture, tell me, I'm taking this for last 10 years without failure, without charges, full dedication, full commitment, no laziness, full energy. That is my commitment. So if you keep the half commitment, then my 100% I can give you written guarantee you will pass. But you need to make something for yourself, right? You need to be more sincere. I'm not telling you personally, in general, I'm telling you. So try to organize your stuff, try to concentrate on your weakness. That is most important. And you get to know your weakness only, and only by mock test. There is no other way by which you can reassess yourself that how you are going. Who will going to I mean assess you? Tell me, do you have anybody who can assess you, sir, how you are going? What's your
No.
score? Where is the weakness? What topics you don't know? Right? How is your preparation going? What do you think whether you pass or fail? Who will going to ask you? No one. Not your wife, not your brother, or not your brother. They think that okay, my son is doing, my hubby is doing. That's it. Nobody is care about it. You need to do it by yourself. You need to make things properly, right? Otherwise it's not difficult exam. I have student who crack, fail 3 times, 4 times. I have student 3 time hard fail, 3 time MOH fail, 2 times DHA fail, 9 trial they pass. I have name number, I can give you, they pass. So I did not need anything, I just given them the pathway that okay doctor, I mean I was also worried na, 8 times they failed, 8 times, 3 DHA, 3 hard, last chance MOH or something, blah blah, whatever, right? So I'd given the path, they cracked in 3 months, that's it. Just preparation is not sufficient by my experience of many years. You need to know what exactly you are preparing and from where you are preparing and how important the material is, right? Because when you are looking this file, that file, I'm not criticizing anything, but how, right? They probably answer is right or wrong, you don't know. Explanation is there or not, picture is there or not. Gleason score, until and unless you see the slide, how do you get to know that what is a Gleason score? I give you 1 hour lecture dedicated for prostate cancer, you don't understand, but you need some picture, and this picture is not available. I'm sending this PowerPoint and this video with you. You go and find out in 100 books. You will not get. I also myself doing lots of exercise before presenting. Though I don't much need to prepare. I'm doing this 1,000 times, but every time my commitment, how I can deliver the best of the best of my knowledge in 1 and 1.5 hour. That is my commitment. That is why every time I'm coming up with new questions, slides, answers, explanation. That's it. So anyway, thank you very much for your kind presence and attendance and this interaction. So just keep in touch and stay tuned. You have any difficulties, problem, anything this need to discuss, feel free to call me. Here is my number. You can see here below 982500. This is my number. So feel free to call me. Thank you very much and enjoy your Sunday.
Thank you, sir. Thank
Thank,
you, sir.
thank you so much,
Thank you,
sir.
sir. Thank you.
Thank you.
Thank you, sir.
Thank you very much,
Thank you,
sir.
sir.
Thank you, doctor.
Thank you so much, sir.
Bye, sir.